suggestion. Yes. Screen visible?
Yes, sir.
Okay. So the topic is end of care life, the challenges and solutions. So first you have to define what is end of care life. It refers to health care for a person nearing end of their life or in their terminal or suffering from a terminal illness. This is the definition. So your answer should first define what is the meaning of end of care life. Then next, coming to the challenges faced by patients who are at the end of their life, that is, who are terminally ill and who are nearing their death. One is pain. Majority of these patients are patients suffering from end-stage cancer, beyond stage 4 cancer, for which there is no complete cure or there is no point of treating them further and wasting the money and causing them more harm by the treatment pattern like chemotherapy and radiotherapy. So freedom from pain ranked most important in consideration of end of life, especially cancer related pain is very, very common. So elderly people often willing to report their pain because they believe it is normal symptom of aging. They don't clearly say that, and they don't think or directly associate with their illness. And as age advances, actually all the functions in the body are reducing. After the age of 40, all the systems start declining in their functional ability. So renal and hepatic function also declines, which predisposes the elderly patient to side effects and toxic effects of medications. So to treat these patients who are terminally ill, they have to use very high doses of medications, and these medicines will not be properly detoxified in the body, and their side effects also will be worsening the condition of the patient. And pain is a notable risk factor for depression and suicide. So these patients become mentally depressed and always think, why do I live? Why can't I just go away? Why can't God take me? All these thoughts will come to them at the end of life. So that also we have to look into. The second thing, as a consequence of this constant pain, people develop depression. So depression occurs in 45% of the terminally ill patients. And this always leads to the thought of suicide. And second thing is anxiety also coexists with depression. They always have a sense of anxiousness and they always have some fear that there is no help for them and they are not able to control their emotions. Suddenly they will cry, they will start getting agitated. So their mental capacity also gets altered. Then physical symptoms of terminal illness and its treatment generate neurovegetative symptoms of depression like fatigue, decreased sleep, weight loss. All these things can happen because of the depression. The third challenge is coping with the situation. Challenges of coping with their disease and their daily living. Probably their mobility will be restricted, their day-to-day minimal activities also will be affected. All these things will face a challenge. Even to get up from bed and go to the restroom and ask themselves, all these things will be a challenge every day. Activities of daily living will be affected. And this causes suppression or isolation of effect and non-compliance. Sometimes they become very have a sense of refusal. They fail to cooperate. So all these things happen because of their inability to cope up with their daily routine. And so non-compliance remains the number one modifiable risk for unfavorable outcome of the psychological problems in this patient. The fourth problem is maintaining the dignity of these patients. The primary illness related concern is the preservation of dignity. It is defined in terms of being worthy of honor, respect, and esteem. So once the patient has a mental disturbance and they are not cooperative and they get agitated, they become suddenly depressed and start weeping, the attenders are likely to get affected by that. And they may feel this patient is a nagging disturbance to us, and they start ill-treating them. So their dignity gets affected, and that worsens the condition. So they should be treated with empathy, and always you should ignore their psychological tantrums and try to keep them calm by respecting their wishes and trying to be cooperative with them. So dignity is directly related to the level of independence and autonomy of the patient through the course of the illness. Then the fifth thing is the need for control. Some terminally ill patients maintaining a sense of control is a central task of dying process. What does it mean? The need for control is a prominent among patients who request physician-assisted suicide. So these are the people who have the mental stamina to say, Doctor, I don't want to live anymore. Worse life than a dog. Please help me to pass away. So the symptoms associated with the risk of physician-assisted suicide are pain, dyspnea, and fatigue. These things provoke the patient to ask for something like a mercy killing. And in addition, wanting to maintain control and not wanting to be a burden on others. Some people feel, especially people when they have restricted mobility, they uh, expect someone to help them for even minor tasks of going to the restroom, having a bath, changing their clothes, eating their food. For everything, they need somebody to help and assist. They start developing a feeling that they are burdening the other people and they are causing more suffering to the kith and kin who are near them. So this is also they want to have a control by ending their life. So they want to control both the timing and manner of their deaths. For most of these patients, the request is persistent, forceful, and often accompanied by refusal of palliative treatment. So once they start developing this need for control attitude, they keep on bothering you or pestering the physician to say, please end my life. I don't want to live anymore. Like that, they will be pestering, persistent all the time, and they will refuse all treatment. They won't take the tablet, they won't take the injections, whatever is given for their pain relief and other things. Then the last thing, other aspects of the dying process, the patients who reach end stage of advanced illness may also suffer from other various complications. Like they may have anorexia, weakness, sexual dysfunction, and multiple interacting symptoms contribute to suffering also. So these other comorbidities also worsen the depression, cognitive disturbance, and they may, if they are living in a fast pace where many patients are there, they may be very combative. They may go and fight with their fellow people living in that same hospice institution. So that sort of behavioral change also will happen. And dying patients and their families often have a deal with complicated practical issues like financial and legal issues. So if the patient is not able to have enough funds to treat their own problem, then some NGOs or some well-wishers, philanthropists will come to help them. Otherwise, the family may sometimes abandon them because they also cannot afford the finance for the treatment. So that will become a big problem. The second thing is if they are very wealthy, then there will be a question of the legal heirs fighting for the wealth of this person. And that also can lead to problems in the end of life. So these are the challenges faced by the patient. These 6 things you have to write in this answer. Now coming to the challenges faced by the clinicians involved in the end of life care, they are most of the time this is not a common specialty that every doctor will try to pursue. Those who are interested in palliative care, they only take up this end of life care treatment for patients. So you have physicians who are not adequately trained, and there is not enough compensation monetarily for the doctors working in this particular field. Like other areas, it's not a lucrative practice for you, so insufficient compensation is there. And seeing these patients dying every two alternate days, some old people living their entire life will be dying. So repeatedly witnessing the death also causes some amount of depression on the part of the doctors treating these patients. And this is the first price for quotation. There is an end to cure, but there is no end to care. So you have to give care to these patients till their even if you stop curing or treating the patient, you have to care them till their last breath. So end of life decision should not be made at the end of the life, but it should be taken well in advance. And some cause happiness wherever they go, others whenever they go. This is the famous quotation by Oscar Wilde. So some people who are very good in their conversation or in their talks, who are able to mingle well, whenever they go and join a company, they will create happiness there. But people who are nagging, pestilent, and combative, people will feel that if they leave the place, they will be very happy. So these are the things that happen. And here comes the other challenge of withholding or withdrawing life care support. This is the third aspect of end of care. So first aspect we saw what are the challenges faced by the patient. Second aspect we have to talk about the challenges of the physician. And the third aspect is because they have reached their end of life. Is this humane or is it ethical? Is it according to the Hippocrates oath to withhold or withdraw the treatment and hasten their end? Is it correct to do that? Sometimes a decision has to be taken to withdraw or withhold life care support in the interest of the relief from the terminally ill patients. In this context, the principle of double effect is practiced. So the double effect concept or the that the decision is practiced here only in withholding and withdrawing life care. So what is this double effect? Any treatment administered in addition to producing the expected benefit may also harm the patient because the dosage required to achieve the benefit will be so toxic or it will be beyond the uh, standard pharmacological dosage. So this is called the double effect. For example, in advanced patients with cancer who are suffering from cancer pain, we start escalating the dose of oral morphine. We start with 5 milligram, then we go to 10 milligram. If you go and see in some of the palliative care units, patients may be taking as high as 60 to 80 milligrams of morphine because over a period of time they become tolerant to the drug and the drug fails to provide that pain relief. So when you start increasing the dose, what happens? It gives a good pain relief, but it will also lead to the side effects of the morphine like respiratory depression, constipation, nausea, vomiting, all these things. So on one hand, it relieves the pain. The other hand, it produces the toxic effect of this drug. This is what is called the double effect. So you get the expected benefit. At the same time, it causes the harmful effects of the drug because of overdosage. So this has to be practiced. We have no other go because unless we give such high dose, the patient is not going to get relief of his pain. So by deliberate administration of the drug with intention to harm is called euthanasia. If you even when the patient is not having any pain, you give him 100 milligrams of morphine or give IV pentothal. That is euthanasia. On the contrary, if you just give it for the benefit and the patient suffers from the side effect, that is double effect. So the physician taking care of end of care life patients should possess the following qualities. They should have wide experience in understanding the mental and physical conditions of the patients. They should have a detailed information about the nature of illness and the treatment offered and what should be the future treatment plan. They should preserve the autonomy and dignity of the patient. So patients' wishes should be respected, and they should listen to the patient and family with empathy and offer comfort and solace. And they should be well versed with medical, legal, and religious practices in dealing with such patients. So these are the points that you have to remember for end of life care. You have to divide the answer. First, definition of this topic and end of life care. Second is to write about the challenges faced by the patient. Third part is the challenges by the to the physician. And lastly, whether to withhold or withdraw, what are the plans that you have to do for the treatment withholding or withdrawal. That if you divide into these three categories, then your answer will be complete for this. A slightly grey topic because it is not a common thing that all anesthetists actually come across day to day. Unless you want to become a palliative care physician, this is mainly for exam purpose how to present this answer. Okay.